هي شفتي كنت أروي حق الجؤاد عادي مرة أخرى في الحياة.
الماجد
يطلع الصورة هي.
كيف حالك يا برف؟
مساء الخير دكتور أحمد، كيف الحال؟
مساء النور، جمعة مباركة. كيف أنت؟ كيف حالك؟
الله يديك العافية ويسلمك. يبارك في العافية إن شاء الله. كيف صحتك أخي؟ كيف العمل؟
الحمد لله إن شاء الله تمام. أنتم كيفكم؟ كيف الأمور؟
الله يديك الصحة والعافية. الحمد لله الحمد لله. كيف النت عندكم اليوم؟ تمام؟
والله إنه أحيان بأحيان ما أضمنش يعني أماكن ما أدري كيف، لكن إن شاء الله يكون
إن شاء
خير.
الله إن شاء الله تمام إن شاء الله تعالى.
إن شاء الله. أنا بعملك الحين، بعملك كو هوست بحيث إنه إذا حصل فصل النت من عندي أو شيء يستمر من عندك. تمام.
يعني أكمل من عندي لو انقطع من عندك، يعني بدي أعمل لهم تقديم
يعني
وبعدين
من عندك يستمر كل شيء على ما هو. تمام. بس
إيه.
قاعد أنت الهوست الأساسي إذا حصل.
أوكي كذلك. يعني أنا أقدم، بس يعني بعد ما تقدم أنا أعرف بالإخوة هذه يقدموا المحاضرات
أنت
واسمائهم
اللي أنت
والمحاضرة على
المدير،
كل
أنت
واحد.
مقدم تعمل كل شيء يا دكتور. إذا أنت أنت الزعيم اليوم.
الله يفتح عليك، بس أنت يعني تفتح البرنامج وأنا أقدمهم إن شاء الله.
خلاص أنا بدأت أفتح البرنامج وأنت بدأت تقدم وشوف.
أوكي إن شاء الله.
اوكي دكتور بارس already in. دكتور بارس how are you?
Okay, let me open my voice. Okay. Hello again. Hello, Professor Amer. Good
Hello,
evening to
hello.
everyone.
Good evening. Good evening. Nice to meet you, inshallah. Thank you very much for joining us. Thank you very
Oh,
much.
okay. I appreciate it. I'm honored to be called to this meeting. Thank you very much again.
You're welcome. You're welcome. Thank you very much. Thank you very much, Doctor.
Doctor, you can check for screen sharing if you want. We still have
Oh,
7 minutes to start, but you can just check for screen sharing if there is any problem, so we can solve before in hand.
okay. Just one sec.
Okay, I can see screen. Okay, Doctor.
Actually, I'm gonna use the presenter view. Do you see now regular slides or my presenter view?
I think I see your presenter view. It's not in full screen. I see small screen in the upper left corner and the remaining slides in the bottom. It's not on full screen mode. Yes, now it's great. That is perfect.
Like I'm changing now. Does it change with you?
Yes, now it's full screen mode. Now it's perfect.
Okay, now it's full screen with you. Okay.
Yes, that is great.
Okay.
So I think there is no issues here. We should start in about 5 minutes. I will do introduction of the program and Dr. Majid Amir. Then he will introduce you and we can start the sessions. Okay, Doctor?
Okay. Also, now I begin to use a laser pointer. Do you see it on the screen?
Yes, I can see it. That's perfect.
Okay, nice.
Okay. We should start first with Professor Yusuf. Then will be your presentation. I think the doctor is already in or no? Proceed. We can check with him about How are you, Nargiza? Good evening.
Good evening. Good evening, Dr. Baris. Hello.
Hello, Nargiza. So nice to see you.
Me too. Last week the meeting was canceled because I couldn't join. I was not able to join last week, but I saw announce again and I was so happy.
Yeah,
Last
I
week you
think
had
there was
some issues. Yes.
yeah, some small technical problem, but
Okay.
anyways,
But that's great. I didn't miss anything.
yeah.
Okay.
Actually, I'm very glad. So I prepared better for this day now.
Okay, great. Dr. Ujel is here. We are
Uh,
also waiting for
I
him.
just contacted him. He will join us now, I think.
Okay. Mhm.
He said that he had an emergency, so he can present, and then he will leave after the presentation.
Okay.
Okay. Uh, Okay, so Dr. Baris, I think we will start with you because Dr. Yusuf will be a little bit late. So in 3 minutes, we should start in 3 minutes, inshallah.
Now I think you're in full screen. Am I correct?
Yes, it's in full
Yes,
screen.
you are in full screen. Yes, Dr.
Okay. So I can begin, Professor, whenever you say.
Okay, in 2 minutes, I will give welcome to the audience, and then Dr. Maidamar will introduce you, and you can start, inshallah.
تبي كمان تبي يبان انه صورتي واضحه ولا
مش يعني قطع انتم راح صوت صورة
I think it's already time, so we can start now.
Okay.
Welcome everyone to the second module of the Comprehensive Neuro-Anatomy Educational course that organized by the Yemeni Neurosurgical Society in collaboration with the WFNS, Young Neurosurgery Forum, and Neurosurgery Coach, along with Pakistani Society of Neurosurgeons, and also Neurosurgical TV. Today, we will start our second session of the Module 2 that will concentrate mainly on the cerebral anatomy. And Dr. Majid Amir, Professor Majid Amir, the head of the Yemeni Neurosurgical Society, will be moderator of the today's session, and he will present our speakers. Dr. Majid, please unmute Dr. Majid, you are muted.
Dr. Ahmed, thank you very much for your planning to do for this scientific program, and I would like to thank our guest who will share us today in the introduction of the lectures about the anatomy. Can we start now with Dr. Yasil? Dr. Yasil, the health science from the Health Science University.
Dr. Majid.
He will talk about the microsurgical anatomy of the temporal lobe. Can you hear me, Dr. Ahmed?
Yes, Dr. Majid. Dr. Yusil will be delayed. We will be late a little. Dr. Yusil will be late, so we can start with Professor Baris.
No, Dr. Baris.
Yes, You can
Uh,
introduction, please.
Sorry for that. Dr. Baris, we'll start with Dr. Baris, the associate professor at the Istanbul University, comprehensive in Turkey. He will talk with us about the anatomy applied and applied anatomy of the Sylvian fissure and the insula. But in the screen, it's the microsurgical anatomy, Dr. Ahmed.
Dr. Baris?
Professor, hello to everyone again.
Dr. Baris.
Today,
Yes,
please, Professor.
yes, you can. Dr. Baris, yes, it's time to start, please.
Okay, thank you.
You'll talk about the microsurgical anatomy of the temporal lobe
Yes.
and Salkai and gyri and the functional
Okay.
regions. Can you
Yes.
start, please?
Thank you for the invitation and presentation to me. Thank you. And with your permission, I'm beginning my session with the microsurgical anatomy of the temporal lobe. And I will be mainly speaking about the microsurgical anatomy with gyri and the sulci. And of course, in the meantime, I will be speaking about the functional regions of the temporal lobe. So now we are looking to the left hemisphere. All the vessels are removed, arachnoid are removed. There we see the frontal lobe, parietal lobe, occipital lobe, and the temporal lobe. As I said, temporal lobe forms the cerebral cortex together with the occipital lobe, parietal lobe, and the frontal lobe. It is located over the middle fossa inferiorly and greater sphenoid wing anteriorly. Superiorly, the temporal lobe is limited with the Sylvian fissure. The temporal lobe is separated posteriorly from the occipital lobe by the lateral parieto-temporal line, which is an imaginary line connecting the preoccipital notch to the preoccipital notch to the parieto-occipital sulcus. So let's draw an imaginary line from parieto-occipital sulcus to the preoccipital notch, and this imaginary line separates the temporal lobe from the occipital lobe. And the temporal lobe is separated from the parietal lobe with another imaginary line, which is occipito-temporal line, a line connecting the most posterior point of the Sylvian fissure with the lateral parieto-temporal line. So two imaginary lines limit the posterior limit of the temporal lobe with the parietal lobe and an occipital lobe, but it is separated from the frontal lobe with the Sylvian fissure. However, the temporal lobe do not only contribute to the neocortex, it also hosts major parts of the limbic lobe, which develops emotions as well as unconscious associations between our five senses. Here we see a drawing of the limbic lobe. Nearly all of the parts of the limbic lobe, like the cingulate gyrus, the fornix, the stria terminalis, stria medullaris thalami, and uncinate fasciculus, nearly 5 of 7 parts of the limbic lobe are involved into the temporal lobe. So the temporal lobe hosts both neocortical activities and also limbic lobe activities. This functional part of the temporal lobe is unique because frontal, parietal, and occipital lobes do not host such double functions. So let's look again what I'm trying to say. In older times, when the Broca defined the Brodmann areas, like Broca area, the Brodmann talked about a locationism function of the neocortical part. But nowadays, we understand actually the areas like Broca area or Wernicke area doesn't make all the functions by itself. actually there's a great connectivity of the all of the brain. So basically nowadays we believe or we think more that the cerebral functions are formed by the connectivity of the different cortical areas by white matter tracks. Actually, there is another topic which I will just say the name, holotopic organization model of the brain, which means that actually with each function, actually all parts of the brain are in the work to make that function. But now we'll be speaking just about the connectivity part of this function. So what I mean is this: when we look to the functions of the temporal lobe, which is my topic today, there are several, but mainly four different functions of the temporal lobe, which is first the semantic processing. Semantic processing means that we understand what the people are speaking and what we are speaking back, which is mainly formed in the lateral neocortex at the superior temporal gyrus and middle temporal gyrus and deep to the superior temporal sulcus. I will be showing these, but also deep to the neocortex, there are superior longitudinal fascicle and arcuate fascicle. So both cortical and subcortical areas or structures are forming this semantic processing together. So when we go back, and nowadays we don't believe anymore that we don't think anymore that the functions of any area of the brain are not processed in strict locations, strict cortical locations. But on the other hand, we think that the functions of the brain, particularly the temporal lobe, are produced by the connectivity of the different cortical areas by white matter structures. So let's go further. Again, at the temporal pole, there is emotional processing and other functions, but not only with the cortical temporal pole, but also there's a white matter tract called uncinate fasciculus, which connects the temporal lobe with the frontal lobe, which makes the emotional processing. When we go further, then we'll see the inferior neocortex of the temporal lobe, which helps with visual processing, which is held at the inferior temporal gyrus and anterior part of the fusiform gyrus, but connects these areas with the occipital lobe with the inferior longitudinal fascicles. Again, two cortical areas, inferior temporal and fusiform gyrus, connecting with the occipital lobe with the inferior longitudinal fascicle. And also, of course, the mesial part of the temporal lobe formed by the parahippocampal gyrus, hippocampus, and the cingulate system, which is connecting with the limbic lobe. Let's go further again to the anatomy. From now on, we'll be seeing both cortical areas and subcortical areas forming these different functions. Now we look closer to the first image. Here we see the temporal lobe a little bit more closer. There are mainly three gyri at the lateral surface of the temporal lobe: superior temporal gyrus, middle temporal gyrus, and inferior temporal gyrus. The superior temporal gyrus and the middle temporal gyrus are differentiated with each other with the superior temporal sulcus, which is continuous in nearly every case, while the sulcus between the middle and the inferior temporal gyri, which is called the inferior temporal sulcus, is not a continuous sulcus in many of the specimens. As far as I know, there is only 10% of the cases there is a continuous inferior temporal sulcus. In 90% of the cases, there is small sulci forming a longer sulcus at the end. Here we should also speak about the superior temporal gyrus is continuous with the transverse temporal gyri on the Sylvian side of the temporal lobe, which we'll be seeing later, and also the angular gyrus, which is a parietal lobe structure, caps the most posterior end of the superior temporal sulcus. So if we follow the superior temporal sulcus, we'll find the angular gyrus, which is actually deeper into that. We'll be seeing the arcuate fasciculus or the superior longitudinal fasciculus. Then we see the medial surface of the temporal lobe. The mesial surface of the temporal lobe is hidden beneath the brainstem. There is mesencephalon, but the pons and the rest of it is cut and taken out. And when we look a little bit more further, closer, now we see the medial surface of the temporal lobe. As Professor Roton used to commonly express, the medial surface of the temporal lobe is the most complex of the cortical surfaces. Main structures of this surface are the uncus here and the parahippocampal gyrus. There are much more detail, which we'll be seeing followingly, but let me recall that the structures of the surface are involved both in memory with the uncus and hippocampus and visuospatial processing. Cortical relationships regarding this lies at the posterior end of the parahippocampal gyrus, which separates at the end of the calcarine sulcus, which is here, into the isthmus of the cingulate gyrus superiorly and the lingual gyrus inferiorly. Let me phrase it again. The parahippocampal gyrus here separates into two, to the cingulate gyrus with the isthmus of the cingulate gyrus into the limbic lobe, which functions with the memory, and to the lingual gyrus to the occipital lobe with the visual processing. Now we see more closer the mesial temporal structures. Mainly, we can divide this again into the uncus and the parahippocampal gyrus, which is anterior the uncus and the posterior parahippocampal gyrus. Let's look first to the posterior part. I mean the parahippocampal gyrus. The parahippocampal gyrus is a 6-layer neocortical structure, but when it begins to turn to the superior surface of the parahippocampal gyrus, it begins to become a first 5-layered neocortex and then the 4-layered neocortex, which is called as the subiculum. Superior to the hippocampal gyrus, there is a small sulcus called hippocampal sulcus. Superior to it, there is a dentate gyrus, which looks like just our teeth. That's why it's called dentate gyrus. Dentate gyrus is actually the cisternal surface or cisternal projection of the hippocampus, which we'll be seeing further later. And also superior to the dentate gyrus, there is fimbrio-dentate sulcus, and superior to it, there is fimbria. So there are, again, 3 structures from superior to inferior: fimbria, dentate gyrus, and parahippocampal gyrus. Parahippocampal gyrus is closely related to the hippocampus, which I'll be speaking on when we look to the uncus. The uncus basically means hook, and just at the most mesial part of it, there is an apex of the uncus, which projects towards the mesencephalon, as you know. There is anterior to the apex, it's called anterior segment, and posterior to it, there is posterior segment. The anterior segment basically has semi-lunar gyrus and ambient gyrus. There is also in between, there is a semi-annular sulcus. The important thing about the semi-lunar gyrus is actually it covers the amygdala, which we'll be seeing further later. Again, the anterior segment of the uncus posterior segment, superior part covers the head of the hippocampus. So again, if we divide the uncus in a superior and an inferior part, the superior part of the anterior segment of the uncus covers the amygdala. The superior part of the posterior segment covers the head of the hippocampus, and the inferior part of the both anterior segment and the posterior segment, together with the parahippocampal gyrus, hosts the entorhinal cortex. The problem here is there are too many functions coming into each other, which all are involved into the limbic lobe functions. So the problem is there are no strict borders where a structure begins or where a functional area begins, but we can at least talk like this, I guess. So, okay. Then we see the inferior or basal surface of the temporal lobe. Laterally, there are inferior temporal gyrus, which is separated by the occipital temporal sulcus with the fusiform gyrus. And more medially, there is renal sulcus anteriorly and collateral sulcus posteriorly, which separates the fusiform gyrus from the parahippocampal gyrus posteriorly and the uncus anteriorly. As I said, the apex of the uncus here, there is the anterior segment, which hosts the amygdala and the head of hippocampus, and the posterior segment. All this surface is actually entorhinal cortex, as I said, which carries the afferent and the efferent pathways into the hippocampus. Now let's remove parahippocampal gyrus and partially the fusiform gyrus to have this. Deep to the fusiform gyrus, we have the inferior longitudinal fascicule, and you see this very thin fibers which connects the parahippocampal gyrus with the hippocampus. As you see, this is the anterior segment, this is the posterior segment. There are small gyri here which are called as intralimbic gyrus and band of Giacomini, and also there was uncinate gyrus. So the names are not very important, but this small gyri was at the posterior segment of the gyrus, more specifically superior to the uncal sulcus, which they were covering the head of hippocampus, which is this, and there later we'll see the amygdala. Let's go a little bit further. We removed those small fibers. Now we see this, you see this dental-like structure of the hippocampus. There we see the fimbria. As I said, there is uncinate gyrus, band of Giacomini, which are situated into the posterior segment of the uncus, while we begin to see the amygdala when we remove partially the cortex of the anterior segment of the uncus. And there is the apex of the uncus. Here we see the optic tract going further. There is mesencephalon, mammillary bodies here, and here we see more posterior the lateral geniculate body which will be important a little bit later. And then we begin to remove the body of the hippocampus. Here we see the tail of the hippocampus. The body is removed. This is the head of the hippocampus. Then we begin to see the fimbria of the fornix. Let's go a little bit further and remove also the head of the hippocampus. And then we begin to see the amygdala, which is situated into the anterior segment of the uncus. There we see the apex of the uncus. Just remember, as I was saying, there is a sulcus here separating the anterior segment of the uncus from the anterior perforated substance. There we see the optic tract going posteriorly to the lateral geniculate body. Just remember, the visual input coming from our eyes goes into the optic nerves, then to the optic chiasm, then to the optic tract, which goes all the way further back to the lateral geniculate body, which is an inferior, posterior, and lateral nucleus of the thalamus. There's also 3 other structures which I would like to mention, because later on we will be speaking about the white matter structures situated at the roof of the temporal horn. Now here we see 3 of those, which are actually most inferiorly. One of them are stria terminalis here, very thin fibers coming from the amygdala. There's a cortical colored structure here, which is the tail of the caudate nucleus. Actually, we know that the head and the body of the caudate nucleus are located at the lateral walls of the lateral ventricle, but they turn all around the thalamus and go to the roof of the temporal horn. And more laterally, we see very thin fibers here, which are the tapetum fibers of the corpus callosum, which go through the splenium of the corpus callosum. We'll see those later. But please again, when we remove the ependyma of the roof of the temporal horn, we see...
Y de hecho mi plan, pues sí dije ayer, ¿no? Que es cerrar columna. Sí, en 2 años.
Okay, actually, okay, thank you. When we remove the ependyma at the roof of the temporal horn, we see 3 structures, connectivity structures, which the first of them is stria terminalis, connecting the amygdala. The second one is the tail caudate nucleus, and the third one is the tapetum fibers coursing through the splenium of the corpus callosum. When we remove the stria terminalis, tail of the caudate nucleus, and the tapetum fibers, then we begin to see another set of fibers coming out of the lateral geniculate body. You see, there I removed the optic nerve, optic chiasm, and the right-sided optic tract. I removed it to see the ansa pedicularis fibers, which are deep to the anterior perforated substance. These ansa pedicularis fibers are another set of connectivity of the amygdala with the stria terminalis fibers, which are removed in these pictures. Let me go back. These stria terminalis, and there is anterior perforated substance. When we take out that partially anterior perforated substance, then we see the ansa pedicularis fibers, which connects the amygdala with the hypothalamus. And then we remove the stria terminalis, tail of the caudate nucleus, and the tapetum fibers, and then we see the fibers coming out of the lateral geniculate body, going all the way around at the roof of the temporal horn, which will then further turn back
Pero es
and
que
go
desde
to the
el
occipital
programa
lobe,
ve, güey, o sea, su
which
programa
are
es...
the visual or visual occipitospatial pathway, or in short, they are optic radiations. And the most anteriorly, they are called as the Meyer's loop, which, as I say, turn around and go then back further. Okay. When we go back, all the way back, now I think we understand that these neocortical structures actually hide a lot of functionality deep to them. Therefore, many functions and many connectivity, both some of them are big, some of them are small. This is a very complex structure. Not only the neocortical structures and even the functionality and the connectivity is to it. Just, I would like to you to focus onto the dentate, to this area, both the dentate gyrus and as I said, the inferior surface and a little bit the mesial surface of the parahippocampal gyrus are actually 6-layered cortex, and when they turn superiorly, the superior surface of the parahippocampal gyrus is the a 4-layered neocortical activity, which will be when we go into the hippocampus, it will be a 3-layered structure then. And just please see here the dentate gyrus, because when we look for this view here, this is the number 12 is the into detail with the CA1, CA2, and this turning hippocampal structure. But just remember the number 15 is the subiculum, which is the 4-layered cortex of the superior surface of the parahippocampal gyrus. And then when it begins to be the hippocampus, it becomes a 3-layered cortical structure. Mesially, as I said, there is dentate gyrus. Superior to it, there is fimbria of the fornix, and there is ventricular side. Okay. Let's go a little bit more basic now. Now we see the Sylvian fissure split on the left side. We see the superior surface of the temporal lobe. Anteriorly, there is a smooth surface called as the planum polare, and there is then 3 gyri, which are called the transverse temporal gyri. Particularly the most anterior one is an important in the speech function, which is called as the Heschel gyrus. So we can say the most anterior transverse temporal gyrus is called as the Heschel gyrus, and there is then planum temporale, which hosts the middle and the posterior transverse temporal gyri. As I told before, the superior temporal gyrus at the lateral surface of the neocortex is continuous with the Heschel gyrus at the superior surface. When we begin to remove this planum polare and the Heschel gyrus, then we begin to see the connectivity of the temporal lobe, the uncinate fasciculus connects the temporal pole with the front deep to the insula, then to the frontal lobe, which we'll be seeing a little bit in detail later. And also there is inferior occipitofrontal fascicule, which connects the lateral neocortex and more occipital lobe, and also the Heschel gyrus, which is removed here, is connected with the arcuate fascicule with the Broca area at the inferior frontal gyrus. Then when we begin to cut those, then we see the important thing at this picture is actually there is a many fibers here, as you see, several of them. The most superficial ones are the uncinate fasciculus and inferior occipitofrontal fasciculus, and more posteriorly the arcuate fascicule, and most deeply at the temporal horn surface, as we already talked, there are tapetum fibers of the corpus callosum and Mayer optic radiations, which we'll be seeing further. Now let's go all the way anterior, remove all the cortex and see first the extreme capsule. There was the insula here. I removed the insula here. I won't be going into the insular anatomy now. So let me go a little bit further. But I can just say when we remove the insular cortex, the first thing we see is the extreme capsule, which hosts the claustrum here. When we remove the claustrum, we see the external capsule, which is not important in my speech, but the anterior part of the this area, there are two fasciculus. The first of them is the uncinate fasciculus, which connects the temporal pole with the and goes all the way around the Limen Insula. There we see the middle cerebral artery. There is the the uncus, and the uncinate fasciculus turns around the Limen Insula and connects the orbital surface or the inferior surface of the frontal lobe. This uncinate fasciculus connecting the inferior surface of the frontal lobe, which with the temporal lobe, makes the emotional functions available. The other fasciculus going through the temporal stem is the inferior occipitofrontal fasciculus, just posterior to the uncinate fasciculus, and it connects the frontal lobe with the posterior parts of the temporal lobe and the occipital lobe, which works closely or making us remember what we see, visual spatial memory, as it's called. So let's look a little bit closer. This is the internal carotid artery. This is the olfactory nerve. This is the optic nerve, internal carotid artery, middle cerebral artery, and this is the Limen Insula. This is the uncus, partially removed, and there we see the uncinate fasciculus going around the Limen Insula, and posteriorly there is inferior occipitofrontal fascicule. And there we see small islands of cortical structures, which is the ventral claustrum. So let's look to the same specimen, but a little bit from far away. The first thing we see here is the superior longitudinal fasciculus, but its anterior connections to the Broca area and posterior connections to the Wernicke area or the Heschel gyrus are removed to see this inferior occipitofrontal fascicule, which connects the middle frontal gyrus, goes over the temporal lobe or goes or courses through at the roof of the temporal horn and goes all the way back to connect the posterior part of the temporal lobe and the occipital lobe. And as I already mentioned, there is uncinate fasciculus anteriorly. The same specimen, but we removed the uncinate fascicule and IFOF. Then we begin to see the second layer of the white matter structures at the roof of the temporal horn, which is the optic radiations. As I told, the visual data coming from eyes through the optic apparatus goes to the lateral geniculate body of the thalamus, and then through that lateral geniculate body, the optic radiations begin to go posteriorly, a little bit laterally, and then posteriorly, and most anteriorly they make a loop, which is called as Meyer's loop, and they go all the way back to the posterior. There we see them, those loops, a little bit better. Just I would like you to see these fibers here. I showed you already the tapetum fibers, which are coursing through the splenium of the corpus. This is the corpus callosum, covering the roof of the lateral ventricle, the body of the corpus callosum, the isthmus of the corpus callosum, and then there is the splenium of the corpus callosum. When we look to the MRI of a patient, basically we first see the forceps major fibers of the corpus callosum coming through the splenium, but also there are tapetum fibers connecting the temporal horn all the way through the corpus callosum to the contralateral temporal horn. But the tapetum fibers are going under or beneath the Meyer loop or optic radiation fibers at the roof of the temporal horn again. This is a very complex anatomy. Please take notes for questions maybe. We can go over them again. And then you see the Meyer loop fibers, they are going at the roof of the temporal horn, but also they turn lateral and a little bit even inferior to the temporal horn, and they go to the occipital lobe. Here we see again. And now I removed the tapetum fibers, and then we begin to see the atrium of the ventricle. There is a lateral ventricle, and there is the atrium of the ventricle. Then we see the choroid plexus. I elevated it to see the tail of the hippocampus here. And I removed all the Meyer loop fibers to see the temporal horn all the way from anterior to posterior. And then we begin to see the amygdala very anteriorly. Now we are seeing the ventricular structures, which we already seen from the cisternal side. There is the amygdala here, and there is the hippocampus, the head, the body, and the tail of the hippocampus, which is covered by the choroid plexus, which is cut here. Then there we see the lateral ventricle, the thalamus, the fornix turning all the way back here, the hippocampus, the amygdala, and this is the atrium. Then we begin to remove the ependyma of the hippocampus to see those internal structures, which are not important because they are so tiny and they're so microscopic. It's impossible to dissect, not impossible, but very difficult, let me say. But just see, there is also these dentate structures here. Actually, that dentate structure of the hippocampus is not seen on the cisternal side. It's actually everywhere. Just the dissection is a little bit difficult, but when you do, it can be doable. Anyways, the important thing here is there is the amygdala, which is situated into the anterior segment of the uncus, and there is the head of hippocampus, which is situated into the posterior segment of the uncus. In between them, there is a recess called uncal recess separating these two structures. Another important thing is my last slide about the neocortical and subcortical structures. Then I will be speaking very shortly on the arterial anatomy and venous anatomy, but very shortly. There is the inferior choroidal point, which is very important in the epilepsy surgery particularly, or when we remove the temporal lobe. The inferior choroidal point is where the anterior choroidal artery enters into the temporal horn to supply the arterial blood of the anterior choroid plexus is the inferior choroidal point is located at the lower end of the attachment of the choroid plexus here, and is positioned just behind the head of the hippocampus. Actually, this inferior choroidal point is the limit between the head of hippocampus and the body of the hippocampus. There I depress the fimbria of the fornix down. The uncal recess, as I told, separates the amygdala from the hippocampus. And as I said, the uncal recess is the intraventricular counterpart of the apex of the uncus. The mesial structures of the temporal lobe is basically supplied by the anterior choroidal artery and posterior cerebral artery. I will be going very fast. As I told, this is again the mesial temporal structures, the apex of the uncus, the posterior part of the uncus, the anterior part of the uncus. Just this is the internal carotid artery. Just remember, there is a small gyrus here, semi-annular gyrus, which is separated from the anterior perforated substance by the entorhinal sulcus, and then we see the anterior choroidal artery coming all passes above the semi-annular sulcus and the uncinate gyrus to reach the lower end of the choroidal fissure, where it enters into the temporal horn. The posterior choroidal artery is removed in this specimen, but when we see from the inferior view, there is the internal carotid artery, there is anterior choroidal artery going here and entering into the temporal horn, and then there is the posterior cerebral artery. I can basically say the anterior choroidal artery is the main supplier of the uncus, and the posterior cerebral artery is the main supplier of the parahippocampal gyrus and the rest of the mesial structures. Here we see an inferior temporal artery coming out of the posterior cerebral artery here. Here, this is the anterior segment of the uncus, the apex of the uncus. The anterior segment of the uncus is retracted to expose the anterior choroidal artery here. And then we see the P1 and basically the P2A segment of the posterior cerebral artery, which courses in the crural cistern next to the posterior segment of the uncus, and P2 segment, but P2P, P2 anterior and P2 posterior segment of the posterior cerebral artery, which courses in the ambient cistern between the mesencephalon and the hippocampus. Again, the P2 segment has two subsegmentation as called as P2A anterior and P2P posterior. The anterior subsegment courses into the crural cistern, and the posterior one courses into the ambient cistern between the mesencephalon and the posterior segment of the uncus, where the third nerve is compressed in uncal herniation, and also the ambient cistern is between the mesencephalon and the hippocampus and parahippocampal gyrus. Here we see from superior, this is mesencephalon, this is the third ventricle, all the basal ganglia above the mesencephalon are removed in this picture to show the posterior communicating artery and the left P1, left P2 anterior between the uncus and the mesencephalon, and P2 posterior between the mesencephalon and the parahippocampal gyrus. And all these small arterioles going into the hippocampal and parahippocampal structures. Again, as I told, basically the uncus is supplied by the anterior choroidal artery, while the posterior cerebral artery supplies the posterior structures. Very complex picture, which we look from inferior. There is mesencephalon in the middle. All the inferior structures are removed to expose the temporal horn, left temporal horn here, the choroid plexus here. On the right, we see the temporal horn, the choroid plexus is cut. On the left, we see the posterior cerebral artery coming here. This is the posterior communicating artery, P1 segment, P2 anterior segment, and P2 posterior segment. There are many, countless, very small arterioles going into the fimbria, hippocampus, and parahippocampal gyrus. But just remember, it gives many perforating arteries into the mesial structures, but then posterior cerebral artery goes back to the occipital lobe as the calcarine artery. We should know it. When we remove the temporal lobe, we should preserve the posterior cerebral artery to preserve the arterial supply of the occipital lobe, and also we should preserve the anterior choroidal artery to preserve the arterial supply of the internal capsule in the basal ganglia. My last slide, even more complex, there is the venous anatomy of the mesial temporal structures. Basically, there are countless variations. This is maybe the most consistent one. That's why I put it here. Basically, the mesial temporal structures venous drainage is done by the basal vein of the Rosenthal, which is at the start formed by the union of the three veins. Here we see only the basal vein, the olfactory vein here, and just a very small vein here next to the optic tract. There is anterior cerebral vein. There should be another one here, which we don't see, the insular drainage vein, I mean the deep middle cerebral vein. So this deep middle cerebral vein coming from the insula, from the sylvian fissure, connects with the olfactory vein and then the anterior cerebral vein. So the union of these three veins forms the most anterior part of the basal vein of the Rosenthal, and then joins the peduncular vein coming from the interpeduncular fossa, and then they course back as the basal vein of the Rosenthal to go into the vein of Galen together with the internal cerebral veins. This is another view. This is the deep sylvian vein. This is the anterior cerebral vein, and there should be a third one, as I said, the olfactory vein, and then joins the peduncular vein and goes all the way back as the basal vein of the Rosenthal to join with the vein of Galen together with the internal cerebral veins. Thank you for your patience. Thank you very much.
Thank you very much, Professor, for this lecture.
Dr. Baris, thank you very much for this. Actually, you chose the very, very complex and very difficult topic in the anatomy and function of the temporal lobe, which we, as much as we can read about this, we cannot collect all of these informations. I'm talking about myself. I had to read about the temporal lobe and the insula. It's actually very difficult to remember all of these information about the anatomy and the functional points of the temporal lobe. Thank you very much. If you have any question, Dr. Ahmed, about the topic from the chat.
Thank you, Professor Baris, for this very nice presentation and very thorough information. We enjoyed a lot of this presentation, and we had a lot of new information. Thank you very much for this. We'll see if there is anyone have any questions in the chat. If anyone and want to add a comment or to ask a question for Professor Baris, please go ahead. Is there any questions or any comments?
No
Nargiza?
questions, but that comments. Thank you very much, Dr. Baris. It's as always wonderful, detailed anatomy presentation, and which will be important at all times whenever you're a resident or a young neurosurgeon or experienced neurosurgeon. So thank you for vascular anatomy, which is also important because we never know which arteries we are touching sometimes, especially when we talk about the perforators. So it's important here. It is important to know the detailed anatomy. Thank you so much.
Thank you. Thank you, Nargisa. Thank you for your comments.
I think there is no more questions. No one want to ask a question. The lecture was very thorough and very detailed. I think everything was explained very nicely, and we need time to process all this information. Thank you, Professor.
There's a great amount of data in the literature which came from the laboratory of Professor Roton in the book written by himself, and also in the books in the articles, particularly the articles coming from the Juan Carlos Fernandez Miranda. There are important mesial temporal structure anatomy written in the articles. Actually, what I spoke today is the convolution of many articles together. I hope it was okay to listen to everyone. But there's also there are already many articles which you can read and learn this anatomy, particularly from the lab of the Professor Rotan, I can say.
The presentation was great, and you present this information in very nice and very clear way, so it can save us a lot of time reading. But it's very nice presentation. Thank you very much.
Thank you. Thank you.
Unfortunately, Dr. Yusir will not able to join us because he has an emergency case. He just sent me a text a few minutes ago that he had to scrub and enter an emergency case. So he will not be able to join us today. So we will reschedule his presentation to the next week. So Dr. Majid Amir, Professor, if you have any comments or any...
If you can try to schedule the lecture for the next week, it will be fine, inshallah. I'd like to thank Dr. Baris again for his precise and very fruitful lecture, and thank you for joining us in this educational course done by the Neurosurgical Society of Yemenese Neurosurgical Society. And I'd like to thank you, Dr. Mohammed, for planning for these lectures, and hope to see you in the next week, inshallah. Thank you very much.
Thank you, Professor.
Thank you everyone for joining us, and thank you, Professor Baris, for the great presentation, and hope to see you all next week with more presentations and more information, inshallah. So thank you everyone, and by this we can conclude our second session.
Thank you, Dr. Ahmed. Thank you very much.